Hello everyone, this is Dr. Ankit Singh, your radiology faculty at Global Academy of Medical Education. And today we are going to discuss high topics related to Fmge examination. We will touch upon important topics from the radiology and we'll try to solve the questions and see how we should approach such questions basically. So starting with question number 1. Which of the following statement is true about this condition? Here we can see a X-ray has been provided to us. So first of all, we will see the X-ray and then we will go back to the options. So this kind of question is an example of a two-step question where first you have to identify the condition on the basis of the radiographic image which is being shown to you, which can be X-ray, CT, MRI or USG, anything. And then you have to see that what are the options given related to that conditions, and then you have to identify the correct one. Also at the same time you have to keep an eye open that in the options given in the statement, is it all are true except all of the following are false except, or what is there. So in this it is very straightforward which of the following statement is true about this condition. So first we need to know about the condition which is being shown. So here we can see the X-ray, and in X-ray we can see that there is a diffuse ankylosis along the spine. So this is a diffuse syndesmophytic ankylosis, and this is something which is known as bamboo spine. And this bamboo spine is seen in condition which is known as ankylosing spondylitis. So we will see the options now. So we know the condition. The condition which is being asked is ankylosing spondylitis. And now we will see which of the following statement among the options asked is true. So first is, it is more common in females. As we know, ankylosing spondylitis is more common in males. Typically the symptoms are there will be a pain early in the morning after waking up from sleep. The patient usually complains of pain. So the first statement is false. It is more common in male, and male is to female ratio is 3:1. Second option is, it is associated with aortitis. We know ankylosing spondylitis has some associations which are apical upper lobe predominant involvement in cases of lung, apical upper lobe involvement is there. There is anterior uveitis which is seen in cases of ankylosing spondylitis. There is something which is known as aortitis. So all 3 A's simple to remember. So the second statement is correct. In such a question, whenever you are seeing such a question, you know the answer is B now, but still you just have to give a look to the option C and D because you don't want to miss out ki they are asking the best answer. At times there are 2 correct options and the examiner wants to know the best answer among this in controversial question. It is not that one, but still we will go upon and see what are the options C and D. So the answer for this question is B. Option C is seropositive spondyloarthropathy. This is incorrect. We know that ankylosing spondylitis is a seronegative spondyloarthropathy. And Bouchard's note is something which is not seen in ankylosing spondylitis. It is seen in cases of osteoarthritis. The second part is very correct mention that it is seen in PIP joint. So there are 2 notes. One is Bouchard's note and another one is Heberden notes. Bouchard's note is seen in PIP joint and Heberden notes is seen in DIP joint, and both these conditions are seen in osteoarthritis. So a simple mnemonic to remember. How to remember that? पहले कौन सा आता है in alphabetical? B comes earlier, so B is proximal. So Bouchard's note is proximal PIP joint, and H comes later in alphabet, then B. So it is distal, that is distal interphalangeal joint, and both this Bouchard's notes and Heberden notes are seen in cases of osteoarthritis. So now we will see some important points. We will study important points related to arthritis here. First, we will see about ankylosing spondylitis. In ankylosing spondylitis, what are the important associations, what are the radiologic findings which has been asked prior examinations and are potential to be asked again in FMGE. So ankylosing spondylitis is also known as Mary Strumpel disease. It is more common in males than females, we know. Most commonly, it happens in young adults in the age range of 30 years. So, a male patient in the age range of 20 to 40, mostly in their third decade, comes with a early morning pain or stiffness. You will advise a X-ray. You will see something which is known as bamboo spine. You can also see dagger spine and other things in ankylosing spondylitis. Whenever we do a CT scan or MRI, so we will see what are the radiographic findings. So one is bamboo spine. We already discussed about it, that in the spine we will see a diffuse syndesmophytic ankylosing. Then there is something called dagger sign. Then there is called squaring of vertebral body. Also there is something called Romanas sign, and this Romanas lesion of spine, also known as shiny corner signs, are better seen on MRI stir image. And apart from that, ankylosing spondylitis, when it involves the shoulder, it causes something which is known as hatchet deformity. Now this hatchet word we have heard somewhere also and has been a NEET PG question previously, and the question which was been asked previously is something related to hatchet facies. And this hatchet facies is seen in a condition which is a trinucleotide repeat. I am giving hint. Please have your answers in your mind. And the trinucleotide repeat, another hint, is CTG. The chromosomal defect is seen on chromosome number 19. So what is the disorder? The disorder is myotonic dystrophy. Also, in ankylosing spondylitis, because there is ankylosis and all, the fracture which happens has a peculiar name, definite name given, and which is known as chopstick type of fracture. So at the same time, while we are reading, we will try to complete the spectrum of arthritis. So how we are supposed to approach a case of arthritis if it comes in the exam. So we need to know the differentials also. We know about seropositive, seronegative spondyloarthropathy. So we will go by that. So first of all, whenever a patient you see a X-ray, your approach, or a CT, your approach should be first you have to look upon the joint space, and in cases of joint space narrowing, now this joint space narrowing, if this joint space narrowing is asymmetric, there are osteophytes and sclerosis is also there along the margins, then you will think of degenerative cause, and that degenerative cause most commonly is osteoarthritis. We know the most common type of arthritis is osteoarthritis, and that the features will be asymmetric joint space narrowing, there will be presence of osteophytes, and there will be sclerosis. But whenever the joint space narrowing is symmetrical, there are erosions, there is soft tissue swelling, we will think of inflammatory cause. So, and that inflammatory cause can involve a single joint or it can involve multiple joint, more than one joint. When it is involving a single joint, we will think of infection. We will think of that infection हुआ है, infection के कारण ये हो रहा है, and then we have to look for the other markers also, like ESR, CRP, the clinical condition also, that will be given in the exam in the stem of the question. If they are saying that more than one joint is involved, then infection is out from your mind. Then we will think of what is the joint involvement. Is it a proximal joint involvement? Plus there is no bony proliferation, or is it a distal joint involvement plus there is a bony proliferation? So that we have to look कि क्या आ रहा है. And if it is a proximal joint plus bony proliferation, we will think of rheumatoid arthritis. Why rheumatoid arthritis? We know that a joint which is not involved in rheumatoid arthritis and which has been asked prior to is a distal interphalangeal joint not involved in RA. So that has been a question prior. So that's why you can remember that it is a proximal joint involvement and not a distal joint involvement. Also, if there is a distal joint involvement, we have to think about seronegative spondyloarthropathy. Now it can be a axial spondyloarthropathy. Axial means along a axis. Suppose this is our body. Suppose this is our body. So if the involvement is in the midline, this is called the axial, and if the involvement is peripherally, that is appendicular skeleton, peripheral, then it is the peripheral in every medical terminology. So axial skeleton, we know in peripheral axial skeleton involvement is seen where the spine is involved, and that arthritis or that involvement is known as, that we first of all discussed in the question, is ankylosing spondyloarthropathy. So that is something is ankylosing spondylitis. And if there is a peripheral involvement, then it will be a peripheral spondyloarthropathy, and then we will think of psoriatic arthropathy, IBD associated arthropathy, and reactive arthropathy. So there can be, so the basic rule is, first we have to look about the joint space. Joint space narrowing kaisa hai? If the joint space narrowing is asymmetric, we have to think about osteoarthritis, that there are asymmetric joint space narrowing, then there is osteophytes. So we will think of, and in the same of the question, there will be a 60-year-old aged who has a difficulty in walking. There will be x-ray of the knee that will be shown to you mostly, or of the hip joint and the others, and you will be asked to come to a diagnosis, or there can be associated question. First you have to identify the condition, and then they will ask questions related to osteoarthritis, like where is the most common sites of involvement, what are the radiographic features seen in it, what can be the other associations that are seen in it, that will be given in the questions as a text form, and then you have to identify the true or the false statement which is asked in the question. If the joint space narrowing is symmetrical, you can see the erosions, there are soft tissue swelling, we will think of inflammatory condition. If a single joint is involved, we will think of infection. If more than one joint is involved, we will think of arthropathies, which can be a seropositive or negative. If there is a proximal joint involvement and no bony proliferation, we will think of rheumatoid arthritis, which is a seropositive spondyloarthropathy. And if there is a distal joint involvement and there is bony proliferations, we have to see axial involvement है, peripheral involvement है. If there is axial involvement, it is ankylosing spondylitis. If there is a peripheral involvement, like the appendices, like the radius, ulna, tibia, fibula, phalanges, carpus, metacarpus, and all are given, we will think of psoriatic, inflammatory, bowel disease associated arthropathy and reactive arthropathy. And all these are seronegative arthropathy. So by seropositive we mean rheumatoid factor positive, and by seronegative we mean rheumatoid factor negative arthropathies. So seropositive and seronegative arthropathy. We will just see how does it look, and then we will have a diagrammatic approach also. I will show you a diagram also. So how in the x-ray they give the erosions, I will just make it for you so that you remember it lifelong. So this is a joint, this is the capsule, this is the cartilage, and these are the areas which are known as bare areas where the joint is not covered by cartilage. And this is the joint capsule, so it is a normal joint. In cases of RA, there is a marginal erosion. So the erosion is something like this, and it happens in areas which is not covered by cartilage. So it happens in bare area. So this is the cartilage, and this is the erosion which is seen in RA, and this is known as marginal erosion. We will see x-rays also. So marginal erosion is seen in cases of RA. Then suppose there is a x-ray where you can see the erosions are terminal along the joint. This is a joint capsule. So within the cartilage, it is not happening in the bare area, like involvement of this area. So this is seen in osteoarthritis, which is a degenerative condition. So you will see osteophytes, that is the subchondral, like the cartilage is involved. So that is something which is seen in OA, and in RA, the cartilage, the joint space here is not involved, but it is involving an area which is known as bare area where the joint is not covered by cartilage. So that is the difference between RA and OA. Then comes the psoriatic arthritis. So what we see there, in psoriatic arthritis, there is bony proliferation. So this is bony outpouching, you can see, and there is central erosion. And because of the central erosion, so this is the bony outgrowth. This is the central erosion which we can see, and because of the bony outgrowth and the central erosion, it takes a shape which is known as pencil in cup deformity. And this pencil in cup deformity, multiple time asked question, is seen in cases of psoriatic arthropathy. Now we will see the last one, which is gouty arthropathy, and this gouty arthropathy involves, so this is the joint, say, I will draw it again. So this is the cartilage we know, this is the capsular area. In gout, the involvement is seen at the site of capsule attachment. So there will be a erosion which is seen at site of capsular attachment at this area. So at this area there is erosion which is juxta-articular at site of capsular attachment, and this is seen in cases of gouty arthritis. And in cases of gouty arthritis, two more important terms we are supposed to know, that the edges, you can see the edges are overhanging. So overhanging edges, if given in the exam, also rat bite erosions. So these points are clinchers which are asked commonly asked in the exam previously also. So these are the points you are supposed to know. That is, the erosion is juxta-articular. In psoriatic arthritis, what we see is a penicillin cup deformity. In case of OA, there is a degenerative osteoarthritis which is subchondral in location. In cases of RA, the erosion is marginal at bare area and it is a normal. Previously discussed, we are supposed to here know what are the seropositive and seronegative spondyloarthropathies. This is the approach you already know, and all these are already asked previously. So all these are previously asked questions. What is the other name of ankylosing spondylitis has been asked in INI previously, and it is more common in male. So now we will see whatever we have discussed in a diagrammatic manner. So here you can see that this is a normal joint where this is the bony part, this blue part is the cartilage, and this area where there is no blue part is the bare area. So in cases of rheumatoid arthritis, the involvement is at the marginal area, as shown. In cases of osteoarthritis, the involvement is at the subchondral area at the involvement of the cartilage. In cases of erosive osteoarthritis, there is involvement of the cartilage, and at the same time there is formation of osteophytes. In cases of psoriatic arthropathy, there is bony proliferations, you can see, and there is penicillin cup deformity because of the central erosion. In cases of gout, the erosion is happening at the area of the capsule attachment. So all these things we have already discussed and seen, and I feel it must be clear. We will see the radiograph also in order to understand. So these are the cases of osteoarthritis, you can see. So now we will trace the margins in order to understand. So here we can see that this is the margin, this is the margin of the joint. So on this side this much space is there, but on the other side there is no space that we can see, so there is a asymmetric narrowing. So on the lateral side, on the fibular side, we can see the space is more, but on the medial side the space is less, so it is a case of osteoarthritis. Also here, in cases of hip joint or left hip joint, we can see that there are erosions, and these erosions are subchondral in locations that at the margin of the joint. So these are cases of osteoarthritis. Now we will see in RA, as I told you, that the involvement is at the bare area, it is not at the joint space. So see, the involvement is here, so it is a normal joint. The interphalangeal joints, but here we can see that the erosions are seen at the bare area. It is not at the joint space where the cartilage is involved, but it is just beside it, adjacent to it at the bare area. So you have to look for these points in the question. Then in rheumatoid arthritis, they can also give you rheumatoid nodule, which is will be a kind of a radio opacity, you can see, and mostly the common sites are at the elbow. So here at the elbow we can see that this is rheumatoid nodule, and it is seen in cases of rheumatoid arthritis. So rheumatoid nodule seen in case of rheumatoid arthritis. Since we discussed in ankylosing spondylitis about the Singh corner sign and all, so we will see that. So this is the Singh corner sign which is seen in cases of ankylosing spondylitis. Here also you can see that just at the edges the vertebra is appearing more hyperdense on CT and it is appearing hyperintense on MRI. The corners of the vertebra are appearing hyperintense. In this radiograph also we can notice that. So this is a shiny corner sign, and this shiny corner sign, also known as Romanas sign. Previously they have asked about Romanas lesion in question, and it is seen in cases of ankylosing spondylitis. So Romanas lesion you are supposed to know. The hatchet sign I told you is seen in cases of humerus. So this is the hatchet sign where you can see that this is a normal margin, but this humeral head here is showing kind of erosion and arthropathic changes, which is giving it a appearance something like that of a hatchet, and that wise it is known as a hatchet sign. Hatchet faces we have already discovered, that is seen in cases of myotonic dystrophy. This penicillin cup deformation, we already discussed about it, is seen in case of psoriatic arthropathy. This is the X-ray, this is the bony growth you can see, and these are the erosions which are being shown here. So this is a case of pencil in cup deformity, which is seen in cases of psoriatic arthropathy. In cases of gout, the most commonly involved area is the MTP joint, metatarsophalangeal joint, that to the first one. So here there are overhanging edges that we can see, the overhanging edges which are known as rat bite erosions, and these are seen in cases of gout. In case of gout, there is a technique where we are able to quantify the amount of uric acid deposition and come to a diagnosis, confirm it, and that we can do by using dual energy. So this is a dual energy image, and these green areas that you can see are the urate crystals which are being deposited, and thus it is a case of gouty arthritis. So see this image. This image can also be shown alone and asked that what do you feel the diagnosis is in this case, and they will give you options of arthritis, and gout will be one of the options, and you have to mark it as a correct one. See another image. So this is a normal CT scan, and this is a dual energy CT which has been reconstructed, and we can see the green areas which are the urate crystals here, and thus it is a case of gout. So a beautiful difference we can see, the soft tissue swelling, the destructions and all, and these soft tissue swelling and destructions are occurring because of this deposition of the uric acid crystals. Thus it is a case of gouty arthritis. So do remember about dual energy CT, and this dual energy CT, they will give image something like this in order to identify. Dual energy CT has also a role in cases of renal stones. In cases of renal stones, in order to identify the stones are calcium oxalate or struvite or uric acid, and thus the management changes on the basis of CT only, that the patient will undergo ESWL or the patient will undergo PCNL. As we know, for radiolucent stones, the ESWL suffices, but if stone is very dense like that of struvite and all, we have to go for PCNL. And stone state and all other complications that are associated with ESWL, we already know, we have studied in surgery. Then there is something called calcium pyrophosphate deposition, and this calcium pyrophosphate deposition causes chondrocalcinosis, that is the calcification along the joint margin, and this is something which is seen in cases of calcium pyrophosphate deposition. So chondrocalcinosis is seen in cases of CPPD, that you are supposed to know, and it is a potential question for the future, that chondrocalcinosis is seen in cases of CPPD. Then soft tissue calcification in distal phalanx. This soft tissue calcification, if given in the options, you have to think of scleroderma. So scleroderma we know can be a diffuse and a limited one. If imaging is given, if they are saying in the statement wise also that there are antibody involvement in medicine and pathology, we know if radiographic image is being given or a radiographic statement is given, like the soft tissue calcification seen in distal phalanx, it is a true statement and a clincher for diagnosis of scleroderma. So in the spectrum of arthritis, this is something you are supposed to know, that soft tissue calcification in the distal phalanx is seen in cases of scleroderma, and pretty well appreciated here. Now we will just revise quickly the golden points and you are supposed to answer. I will just fill in for you people. So RA factor and CPP antibody, the diagnosis will be rheumatoid arthritis. HLA-B27, you are thinking correct. It is something which is ankylosing spondylitis. Soft tissue swelling next to first MTP joint, rat bite erosions, overhanging edges is seen in cases of gouty arthritis. Sausage digit, penicillin cup. Then again it has been asked in INI and also in NEET PG, like fusiform periarticular soft tissue swelling. They have not given terms like sausage digit and penicillin cup for these conditions. They have mentioned about fusiform periarticular soft tissue swelling, and it is something which is seen in cases of psoriatic arthritis. So please remember these important points also, so that you do not miss out or make these simple topics wrong in the examination, which are constantly asked. Also, coarse calcification in subcutaneous tissue surrounding distal ends. I just saw you the condition where there is a diffuse type and a limited type also. It is something which is known as scleroderma. And Heberden's notes and Bouchard's note we studied in the question, and that is seen in cases of osteoarthritis. Where is Heberden notes seen? And Bouchard's notes becomes earlier in alphabet, so it is seen in proximal interphalangeal joint, and H comes later, so it is seen in distal interphalangeal joint. So Bouchard's note is proximal and Heberden notes is distal interphalangeal joint. Now moving to the next question. Which of the following radioactive compounds and their half-life is wrongly matched? So here the options given are iodine 123, the half-life given is 13 hours, cobalt 60, half-life given is 5 years, cesium 137, the half-life given is 30 days, and FDG, the half-life given is 110 minutes. So this is a ratofy type of question where we are supposed to know these facts, and these are something which are supposed to be revised in the last 10 to 15 days of our before our exam, so that we don't miss out on these factual questions. So in this case the answer is C. It is for cesium 137. It is not 30 days. The half-life for this is 30 years. And that's why I have chosen this question, because these are the important ones which you are supposed to know. Iodine 123, 13 hours, cobalt 5 years, and for cesium it is 30 years and not 30 days, and for FDG it is 110 minutes. Also, you are supposed to know about iodine 131, which is 8 days. For iodine 123, it was 13 hours. For cesium, it is 30 years and not in days. Also something which is in years is radium, which is 1620 years. So radium 226 we mostly remember, but cesium we miss out, and cesium is something which is not in years. So these are the important ones you are supposed to know. You don't need to remember the entire list, and you will be able to solve the question in most of the cases. Moving to next question. What is the appearance has been shown, which is, and the question asks, this appearance is seen in all of the following conditions in radiology except. So out of the 5 options given, in which of the following condition it is not seen? So first we will see the appearance. The appearance given is this tram track appearance is seen in what all conditions. So tram track appearance we know is seen in cases of Sturge-Weber syndrome. Tram track appearance is seen in bronchiectasis in the lung. We see in Sturge-Weber in the brain. In optic nerve meningioma also the tram track calcification is seen, but this tram track appearance is not seen in cases of optic nerve glioma. And that is the answer for this question. So this tram track appearance, you are supposed to know that where all these appearances are seen. Also the appearances which have a similar appearance in other conditions also can be asked in future. So such type of questions can be framed, and that's why I have included this. So you are supposed to connect the dots also while you are studying. So the answer for this question is optic nerve glioma, and this optic nerve glioma has a common association with fibromatosis. So, and this is optic nerve glioma is bilateral mostly. If we talk about neurofibromatosis are of two types, type 1 and type 2. Type 2 is also known as Misme syndrome because multiple inherited. There is schwannoma, there is meningioma, and then there is something called ependymoma. NF2, the letter is 2, it is seen on chromosome number 22. NF1 is seen in chromosome number 17, and it has all this optic nerve glioma, sphenoid wing dysplasia, bare optic sign, the leash nodules, and the cafe outlet spots. All you are supposed to know. The cafe outlet spot, apart from neurofibromatosis, can also be seen in a condition when there is a precocious puberty. Then there is a phacomatosis, and then there is another condition associated, and that is known as McCune-Albright syndrome, where you can also see and find cafe outlet spot. Moving to next question. MRI image has been provided, a T2 weighted image. How we are saying that it is a T2 weighted image? We can see the CSF is appearing bright, and we know water is bright on T2. Remember by pneumonic World War II. So it is a T2 weighted image. The CSF within the spinal cord is appearing bright, and also you can see that there are some cysts also. This is the pancreas which is being shown to us, and there are multiple cysts within the pancreas which are appearing hyper intense, appearing bright, strikingly bright. So we have seen the radiographic image which are being provided. It is a T2 weighted image, and in this T2 weighted image there are multiple pancreatic cysts that are being shown to us. The pancreas is kind of almost replaced by these multiple cystic lesions. Now we will study about the question. So in such a question, you first see the image. Always in any subject you are solving a question, if an image is being provided, first see the image, try to see all the findings which are given there, so that you can come to your diagnosis and then the answer very quickly. So now we will go to the question. The question says a 27-year-old woman is referred to the gastroenterology outpatient clinic with a 3-month history of upper abdominal pain. So 27-year-old, there is upper abdominal pain, there is no past medical history, but her sister has a brain tumor. So this condition may have a association with a brain tumor. A contrast enhanced MRI of the abdomen is given below. What is the most likely diagnosis? So in this case, as we can see that there is no, the options given are autosomal dominant polycystic kidney disease. It is not an autosomal dominant polycystic kidney disease because the kidney is not being shown, and these cystic lesions are seen in pancreas. So it is not the answer for this question. Is it cystic fibrosis? Cystic fibrosis, if they provide, they will give you a hint of infancy. Apart from that, there will be recurrent infections that will be given, and gastrointestinal symptoms would be provided like meconium plug and all in the stem of the question, but that is not provided. It is an adult patient. There is no any concept or any finding related to mucoviscidosis, which is the other name for cystic fibrosis. So it is not the answer for this question. Is it tuberous sclerosis? There are no any patches or any skin finding which is given in the question, and also the MRI finding is something which is not related to the stem of the question which is provided. So it is not tuberous fibrosis. So the answer for this is von Hippel-Lindau disease. And now we will study about VHL. VHL is something which happens because of a defect in a tumor suppressor gene which is seen on chromosome number 3. And VHL has a multiple associations, multiple manifestations in different organs, and the disorder can be a benign or a malignant tumor in the form of. Now the associations we can remember by a simple mnemonic which is Hippel. So H for hemangioblastoma of the CNS, which is seen. So in the brain, in the cerebellum mostly we can see a hemangioblastoma. There is an increased risk of renal cell cancer, renal cysts which are found in it. By P, there is in adrenal there is a pheochromocytoma, paraganglioma which are seen. In pancreas, there are pancreatic cysts, cystic adenocarcinoma can happen. There can be neuroendocrine tumors like carcinoid. There can be eye and ear association. There can be retinal hemangioblastoma. Then there can be a ELST, which is a endolymphatic sac tumor. And there can be cyst, which can be seen in liver and renal also. So this is a very simple mnemonic to remember. Hippel. For H, it is CNS hemangioblastoma. For I, it is increased risk of renal cell carcinoma. For P, it is pheochromocytoma. Then again, P is for pancreatic cyst. E is for eye and ear dysfunction. And L is for liver and renal cyst. We talked about cystic fibrosis. Now this cystic fibrosis, if given in the question, the cystic fibrosis will be asked mainly where. So a word about cystic fibrosis. Cystic fibrosis is also known as mucoviscidosis. It is a autosomal recessive condition. And this cystic fibrosis, it involves the exocrine functions like the exocrine function of the liver, lung, pancreas, and those manifestations are there: small bowel, sweat gland. And whenever they are asking you a question, they will give a diagnosis that in the infancy, the patient is presented with meconium ileus. There can be rectal prolapse. There can be recurrent pulmonary infections which are provided in the question. Now the investigations which can be asked in cases of cystic fibrosis is: one is sweat chloride level, and this sweat chloride level, the value which are usually been asked previously, and it is a hot favorite of the examiners, had been asked again and again. The value is more than 60 milli equivalent per liter. And what is the gene defect? It is the CFTR gene defect which is seen in cases of cystic fibrosis. The mutation most commonly seen is delta F508. The drugs which have come up is ivacaftor and lumicaftor. The ivacaftor is most effective in mutations with G551D deficiency, and lumicaftor is in cases of delta F508, and eva plus lumicaftor has been approved for delta F508 mutations. And this, the name of the drug you can easily remember. There is a mnemonic in it also. It is a CFTR gene mutation. So ivacaftor and lumicaftor. So CFTR gene, and the defect is on chromosome number 7q. So for this question we have seen that the answer for this was von Hippel-Lindau disease because of pancreatic cyst. The associations we have seen, and cystic fibrosis, how the question can be asked, and the investigations important: serum chloride test level, the on whenever the mother kisses the baby, he feels a salty odor comes, salty smell comes. that is given will be given in the stem of the question, and also the gene defect is on chromosome number 7q. The mutation is delta F508 or G551D deficiency. Ivacaftor is important drug which is given in cases of G551D deficiency, lumicaftor in 508, but approved for delta F508 mutation is Eva plus lumicaftor, and the defect is on chromosome number 7q. The gene defect is CFTR. Now moving to next question. All of the following are true about the given condition except, so first of all we will see the condition. The condition given is a biconvex linear hyperdensity extraaxial which is seen in skull, and it is EDH which is extradural hemorrhage. So we have to see the statements with respect to extradural hemorrhage, and we have to see which among the following is false, because the statement says all of the following are true except. So first one, craniotomy is the definite management. The answer is, the statement is true. Yes, craniotomy is the definite management. It is done when the EDH amount is usually more than 30 cc or there is a midline shift which is more than 5 mm. Second option is it does not cross suture line. It is a correct. It does not cross a suture line. It is bounded. The one which crosses suture line is SDH. It is associated with lucid interval. Correct. Lucid interval is something which is important from forensic point of view, from medical legal point of view. Lucid interval is an interval of normal intelligence in between two a spectrum of impaired or unconsciousness. So the patient was unconscious for some time, patient becomes conscious for some time, then patient again becomes unconscious. So this time period is a lucid interval, that the time period between two impaired awareness is the lucid interval, and that is seen with EDH. The fourth option, cannot cross midline, is the false statement, because EDH can cross midline. It cannot cross suture, but it can cross midline. So it is a false statement, and it is the answer for this question. Now let's see important points about EDH and SDH. So first of all, another question, mention the most common vessel which is responsible for bleeding in the following condition. So option A, we can see similar picture, biconvex extraaxial hyperdensity. So it is EDH. Here we can see a concave or concavo-convex lens-separated extraaxial hyperdensity. Here we can see dependent level also. So it is a subacute form, and it is SDH which is provided. So in EDS, the most common vessel responsible is artery, that too middle meningeal artery. In cases of SDS, the vessel responsible is a vein, which is a breathing cortical vein. And also important point that we see that EDH can cross midline, SDH can cross suture line. Shape is concavo convex or convexo concave. Here the shape is lens separated or biconvex. So these are important points with respect to EDH and SDH. We will also see something which is known as SAH. So in cases of SAH, there will be bleeding in the subarachnoid space. Most commonly, the hyperdensity along the subarachnoid spaces is seen around the circle of Willis, because in SAH we know that the question it will give it you as in the clinical part as thunderclap headache. The patient with coming and saying he has experienced the worst headache of his or her life and has come up, and a CT has been done, and this picture has been shown to you, and you have to mark it as SAH. You have to identify it as a subarachnoid hemorrhage. The most common cause, the causes of it are trauma, if it happens spontaneously. The most common cause is Berry aneurysm, and because of Berry aneurysm, the bleed is mostly in the sylvian fissure and in the circle of Willis. Here the bleed is shown in the circle of Willis, so mostly it is because of Berry aneurysm. And for aneurysm, we know the treatment can be coiling or clipping. So radiologically, using interventional radiology for aneurysm, we can do coiling, and in that case we have to see, in cases of aneurysm, the dome to neck ratio. If the dome to neck, so suppose this is the vessel and there is a outpouching, so the neck if the neck is wider, the coiling cannot be done simply, we have to put a stent or a balloon. But if the neck is smaller, we can do a coiling without any assistant. So if the dome to neck ratio is more, the coils can easily go and kind of block it. But if the dome to neck ratio is more, the coil will prolapse and come away in the vessel. So we have to put a stent and then do coiling, or we have to expand the balloon for some time, for 2 to 3 minutes, not more than that. Whenever a stent is inside, we have to put it under fluoroscopic guidance in DSA setup and then do it. So it can be done as a stent assisted coiling or a balloon assisted coiling when the dome to neck ratio is less than 2. If it is more than 2, we can do simple coiling. When it dome to neck ratio is less than 2, means the neck is more than the dome, we have to go for a stent assisted or a balloon assisted coiling. And we know these aneurysms are common causes of SAH if they rupture and bleed. In cases of SAH, there are few scoring systems we are supposed to know. In CT and radiology, we something scale, we something rate the SH on the basis of modified fish size scale. There is an involvement of intraventricular extension or not, and what is the thickness of the SH on the basis of that, less than 1 mm or more than 1 mm, or there is an involvement of IVH. You are not supposed to know this, but you are supposed to know the name of the grading system, that is modified fish size scale. Then there is something called Hunt and Hayes scale, and there is something called WFNS scoring system. So these are all associated with SAH and all has been asked previously. So all are high yield questions. And this important point that EDH can cross midline and SDH can cross suture line. EDH cannot cross suture line. You are supposed to remember. Moving to the next question. The question says, a mother gets her child to the OPD with complaints of poor weight gain. On further inquiry, mother reveals that the child is often gruel water in meals. The wrist X-ray of the child is given below. Which radiological finding is a recognized feature of this condition? The options given are cortical sclerosis involving the margin of the epiphysis. B is expansion of the costochondral junctions. C is exuberant periosteal reaction. D is increased density of the end of the metaphysis, and D is metaphyseal spurs. So let's see the X-ray of the wrist which is given to us. So in the X-ray we can see that there is something, that there is splaying of the metaphysis. The irregular margins can be seen along the metaphysis, and there is widening and concavity also, and these are seen in the other joint space also at the end of the margins. And this is something which is seen in cases of rickets. And in rickets we also know that apart from cupping, fraying and splaying, that there is a rachitic rosary, there is expansion of the costochondral junction. So the answer for this condition is B, that is expansion of the costochondral junction. There is no cortical sclerosis involving the epiphysis. The sclerosis post treatment is seen in cases of in the region of metaphysis. There is no exuberant periosteal reaction. Increased density of the end of the metaphysis is something seen post treatment, and there is no metaphyseal spur, there is irregularity and metaphyseal concavity which is seen in cases of rickets. So in case of rickets, what we see in case of rickets, there is a deficient mineralization, and that deficient mineralization is seen involving the growth plate, and this deficient mineralization, it occurs after the growth plate is fused, or in the adult, that is known as osteomalacia. Deficient mineralization of bony matrix. And in case of rickets, why metaphysis is something which is involved mostly? Because the excess of non-mineralized osteoid is seen there, which causes widening and abnormal configuration of the metaphysis. So widening and abnormal configuration of metaphysis happens because of the non-mineralized osteoid, which are mostly seen in the metaphyseal region. Radiographically, what we see is cupping, fraying, and splaying. So what are all these terms? By splaying, we means that there is a widening of metaphysis. By fraying, there is irregularity, and by cupping, we mean concavity of metaphysis. And pseudo fractures are also seen in cases of rickets, and all this cupping, fraying, and splaying are mostly seen in areas which are metabolically active, that is around knee, around wrist. So these are the areas where it is mostly seen along the rib ends, where the growth is greatest. So distal femur and proximal tibia, in wrist involving the ulna, anterior rib ends causing rachitic rosary. Harrison's sulcus is something which is also seen in cases of rickets, and Harrison's sulcus is basically the lower rib goes inwards, so it is drawn inwards, and this is known as Harrison's sulcus. And there can be involvement of the knee and hip also in the form of coxa vera and coxa valga in the hip. Genu vera, genu valga, also protrusio acetabuli is seen, and there is coxa vera, coxa valga, which is seen. And post treatment, whenever we see a biochemical or clinical improvement and radiographic improvement, the radiographic improvement lags behind the biochemical and clinical improvement, and that gap is of 2 weeks between the biochemical and clinical in comparison to radiographic. So biochemical and clinical improvement are 2 weeks earlier, and radiographic involvement we see 2 weeks later than the biochemical and clinical involvement. And what we see Harris growth arrest line. What is this Harris growth arrest line? It is a dense line parallel to metaphysis. So post treatment, we see a dense line which is parallel to metaphysis, and that is something which is known as Harris growth arrest line. Now moving to the next question. So here we can see a VRT image has been provided. The question says a 21-year-old gentleman underwent routine medical examination before joining the armed forces. Ultrasound was done, which shows a dilated upper port calyx with presence of 2 pelvic calyceal system. He underwent CT urography for a detailed evaluation after ultrasound, the findings of which are given in the alongside image. Which of the following statement is incorrect regarding the condition shown below? So here the image is being given, and the image is a volume render technique of a CT, where on the right side we can see the kidney is there is a single ureter going, but on the left side we can see a double ureter, then they are joining and then they are draining in the bladder. So let's see the options. Option A is the diagnosis in the given clinical scenarios a left-sided duplex pelvic ileal system with bifid ureter. The option seems to be correct. On the left side we can see that there are two ureters, so it is a bifid ureter. Seems correct only. Moving to option B, Weigert-Meyer rule shall be applicable in this case. Weigert-Meyer rule we know is for double ureter. So we will read out and see the other statements also and come back to option B again. Doesn't seem right in this case as of now. Option C, according to Weigert-Meyer rule, ureter draining the upper pole moiety has an ectopic insertion medial and inferior to the lower pole renal moiety ureter. This is a correct statement. We know when there are two ureteric insertions into the bladder, the upper pole ureteric insertion has a ectopic insertion and lower pole insertion is a orthotopic insertion. Drooping lily sign is seen in this condition. Yes, drooping lily sign can be seen. So the incorrect statement is option B, because Weigert-Meyer rule won't be applicable in this case because it is not a complete duplication. The ureter are joining in the proximal part only and then they are draining in the bladder as a single ureter. There are no two ureters, which the Weigert-Meyer rule states. So the correct answer for this question is B, which is the incorrect statement for the condition given. So the image that we have given here is a volume rendered three-dimensional CT urography, where it is showing a duplicated pelvic ileal system and bifid ureter. It forms one end of the spectrum of the duplicated pelvic ileal system, and this duplicated pelvic ileal system is a congenital abnormality where the kidney is draining via two collecting systems. In a complete duplication is more common than partial, and it is mostly bilateral where there will be duplication of the entire system. In complete duplication, the ureters draining the two moieties never join. In this case, the ureters are seen joining. We can see the ureters are joining at this place, and then there is a single ureter. There is no two ureteric moiety. So in complete duplication, the ureters running the two moieties, they never join and each has its separate ureteral orifice in the bladder, and in such cases we can apply the Weigert-Meyer rule. The Weigert-Meyer rule cannot be applied in a partial duplication where the ureter has a single opening. So what is Weigert-Meyer rule? The Weigert-Meyer rule says that ureter draining the upper pole moiety has a ectopic insertion which is inferomedial to the lower renal moiety and is often stenotic and prone for obstruction. The ureter draining the lower pole has an orthotopic insertion, that is a normal insertion, and tends to have a vesicoureteric reflux, and all these are hot favorite of the examiners and has been asked again and again previously. So all of these are important potential questions. So Weigert-Meyer rule, which one has a orthotopic insertion? It is the lower pole moiety. Which one has a ectopic insertion? It has a upper pole moiety. It is more prone for obstruction. The lower pole moiety is more prone for vesicoureteric reflux. Vesicoureteric reflux can be applicable when there are two ureteric systems inserting into the bladder. It is not for a partial duplicated system. The drooping lily sign is seen on IVU when there is an obstruction of the upper pole moiety, because of which it seems like that there is a inferolateral displacement of the opacified lower pole moiety due to an obstructed and non-opacified upper pole moiety. So seems like the lily is drooping. In incomplete, the ureters join at a level above the urinary bladder. Yo-yo reflux may occur if urine refluxes from one ureteric moiety into the other rather than draining into the urinary bladder. CT urography is the investigation of choice, and this duplex system doesn't cause problem per se by itself, but it can lead to complications which can sick the patient, which can lead the patients to get treatment. Otherwise, the treatment is not required if there is no complication per se. Moving to next question. A 55-year-old male patient who is a banker by profession presented to the urology OPD with complaints of right-sided flank pain. Ultrasound was done, which showed a renal cyst of Bosnia class 3. Patient underwent CECT of the abdomen, which is shown alongside. What is the most likely diagnosis? So in CECT, he can see that there is a heterogeneously enhancing condition with irregular margins at the upper pole of the right kidney, and nothing else is seen, but the lesion is heterogeneously enhancing exophytic lesion with irregular margins. So let's see the options now. A. Angiomyolipoma. For angiomyolipoma, as the name says, it should have a lipoma fat, angio blood, and myo muscle component. So in cases of angiomyolipoma, what we look for? We look for a macroscopic fat, which is not seen in this case, because macroscopic fat is something which we can see on CT. Microscopic fat we can see on MRI by chemical shift imaging technique mostly. So it is another MCQ that you people are supposed to know. So angiomyolipoma, there is no fat. For fat, what we do, we compare for the adjacent fat. This fat, this dark jet black structure jo dikh raha hai, this is the fat, but this is something which does not have any attenuation similar to the adjacent mesenteric fat. So it is a heterogeneously enhancing condition. The second option is RCC. It seems to be the answer, but let's see other options too. Renal oncocytoma. It is not a renal oncocytoma. There is no scar we can see in the lesion given. Renal cyst. It is not a renal cyst. So the answer for this condition is renal cell carcinoma. So let's see the options. The given image shows a coronal section of CCT abdomen where we can see a heterogeneously enhancing exophytic right renal mass lesion, which is suggestive of renal cell carcinoma. Renal cell carcinoma, known by other names too, which is Gravit's tumor, hypernephroma, internis tumor, radiologist tumor, is a primary malignant tumor arising from renal tubular epithelium. It is a common primary renal malignancy. It commonly occurs in the age group of elderly between 50 to 70 years, and there is a triad with which it presents. The triad is macroscopic hematuria, that is a frank hematuria, flank pain, and a palpable flank mass which is seen. It is associated with various syndromes, that is von Hippel-Lindau disease. We have already discussed about this condition, and we saw that both these conditions are interrelated. VHL has associations in the form of renal cell carcinoma and renal cyst. Birt-Hogg-Dube syndrome, and when Birt-Hogg-Dube syndrome is there, there are various subtypes of RCC. In Birt-Hogg-Dube, what we see is a chromophobe subtype. In tuberous sclerosis, clear cell RCC is seen. Then there can be hereditary papillary RCC, hereditary leiomyomatosis. This is important. It has not been asked prior, but it is a potential question for future. XP11.2 mutate translocation is common in pediatric RCCs. On USG, it shows a variable echogenicity mass with solid cystic component, and since it is a mass, so when we do a Doppler, it will show internal vascularity. CT is the investigation of choice for both diagnosis as well as staging, where it appears as a heterogeneously enhancing mass lesion. MRI is better to look for renal vein or IVC involvement. We know RCC has a predilection for involving the veins, renal vein involvement. So in order to distinguish between a bland thrombus, that is, it is just a thrombus inside the vein and there is no tumor inside the renal vein or IVC, or it is a tumoral thrombus, that the thrombus itself has gone inside, the cancer has gone inside the vessel, and it is not a common bland thrombus. So that is better seen on MRI, and that we say on the basis of enhancement. FDG PET has a limited value in primary renal cell carcinoma because there is a physiological excretion of FDG from the kidneys too. So it becomes difficult to appreciate renal cell carcinoma on the basis of nuclear medicine imaging. So angiomyolipoma, so this is a fat which we can see exophytic fat containing lesion. So angiomyolipoma is a closed differential and it has a presence of low attenuation. So black in color, macroscopic fat. So this is the angiomyolipoma, AML. Option C, renal oncocytoma. It is a predominantly benign lesion and it is characterized by a sharp central stellate scar mostly, which can be easily seen on CT. So this is the scar. Option D, it is a broader term like the renal cystic lesion, and there is a Bosniak system of classification, and on the basis of the enhancement seen on CECT, that is classified. So this is the renal cyst that has been shown here. Now moving to some rapid fire questions type. You people have already uh, so we have now discussed those topics something in detail which can be asked, and just as a revision, it's not possible to discuss the entire radiology in 1.5 hour or 1 hour per se. So I have tried to touch upon topics which have been asked by or which can be a potential question, so that it serves as a quick revision tool for all of you and keeps you motivated, that you understand the topic and you know the topic pretty well and able to answer if the similar question is asked in the exam, and you develop a approach for the question, which is the most important, because the topics are same, the questions can be framed in a different way. When you know the approach to a question, you can approach a question which you have a partial knowledge and come to a correct diagnosis for that particular question. So these are three set of images, MRI images, and you are supposed to answer the MRI sequences in all these three. So A has been asked previously in INI 1 year back. So it is a susceptibility weighted imaging. This susceptibility weighted imaging is mainly done to look for calcifications or the blood vessels on MRI, that they are better seen. We know calcifications are better seen on CT, but we have to see for calcifications. We do a SWAN imaging or a susceptibility weighted imaging, and terminology we use for that is blooming or susceptibility artifact. So this is a susceptibility weighted imaging to look for calcification. In the next image, first we are supposed to see the white matter or gray matter. So here the white matter is appearing white, the gray matter is appearing gray, and CSF is appearing dark. So it is following the rule: white matter is white, gray matter is gray, and CSF is dark. So it is a T1 weighted image. Never try to jump upon and come to a conclusion of a sequence just on the basis of CSF. We will see in the next example. Here, see, the CSF is black, but it is not a T1 weighted image. The reason being, the white matter is appearing gray, the gray matter is appearing white. So it is a T2 weighted sequence which has been modified. So what we do in such cases, we have inverted the fluid part, the fluid which was appearing bright, we have attenuated it to make it look black. So the sequence is known as flare, that is fluid FL, fluid attenuated A, inversion recovery. So it is fluid attenuated inversion recovery sequence. So this is a flare image. So these are the simple images which can be given to you and asked. A single image will be given mostly and asked identify the sequence. They can give you T1, T2, flare, and susceptibility. T1 and T2 we know. T1, white matter is white, gray matter is gray, CSF will appear dark. If in this image, if the CSF would have appeared bright, it would have been a T2, but since the CSF is appearing black, it is a flare. So it is just a differentiating point between a T2 weighted image and a flare weighted image. So you have to look for white matter, gray matter, and CSF signal intensity. And this is susceptibility weighted imaging. So the answer is susceptibility weighted imaging, T1 weighted imaging, and flare. Moving to next question. Identify the eponymous fractures which are given, and which fracture among these two is associated with ACL anterior cruciate injury. So the first fracture given here is a Pellegrini-Stida lesion. Second fracture given is a Sigon's fracture. So in Pellegrini-Stida lesion, the fracture is on the medial side, and in cases of Sigon's fracture, the fracture is on the lateral side. So medial and lateral. And Sigon's fracture, whenever we see on X-ray, most of the times, more than 90% of the times, it is associated with ACL injury. So Sigon's fracture is something which is associated with ACL injury, and in knee we know the cruciates are the crucial ones. So ACL and PCL are the important ones we are supposed to know. So remember, Sigon's fracture is associated with a crucial ligament injury of the knee, which is the anterior cruciate ligament. So ACL injury associated with Sigon's fracture, which can be seen on X-ray, and we can make a indirect inference of ACL injury. Next question, a young child presented with complaint of difficulty in swallowing. CT angiography of the child is shown in the image. What is the most probable diagnosis? That is the first part. The second part is which vessel is responsible for this condition and what is the exact developmental cause for this condition. So it is a OSCE type of question. In such questions, since this concept has been asked again and again in the examination, it becomes a must to know for each one of you. So what is the most probable diagnosis? The diagnosis in such case is dysphagia lusoria. We can see there is an aberrant subclavian artery which is going behind the trachea and the esophagus, and it is causing compression over the esophagus. So suppose this is the esophagus, the vessel, instead of coming anteriorly, usually the subclavian artery on the right side is coming from the left-handed side, and it is going behind it, and then it is causing compression from behind. So because of the compression from behind, there is a difficulty in swallowing. So the answer for this is dysphagia lusoria. Which vessel is responsible? It is a right subclavian artery, and that too aberrant right subclavian artery, because of the aberrant course of the right subclavian artery. And what is the reason for it? The aberrant right subclavian artery goes in front of the esophagus, compressing it, where there is a disappearance or obliteration of the fourth artery. Embryologically, there is persistence of the caudal part of the right dorsal aorta, leading to formation of an abnormal subclavian artery. Now, few interesting connect the dot points. You have to see few of the images. I will give you 5 seconds. Keep your answers in your mind, what you think, and then I will tell you the answer. Also, it will serve as a mnemonic for you to remember the condition, the high yield points related to the conditions, the triad of the conditions which are usually asked. So question 1, see, few hints are given. You can see a tram track appearance is given, a CT head abdomen NC-CT scan is given, where you can see these hyperdensities. Decreased field of vision from glaucoma is given, and there is something port wine 1000 which is given. So all of this port wine stain, the tram track calcification, and glaucoma all are pointing to a condition which is known as Sturge-Weber. I guess all of you have thought it correct in your mind, and the condition is Sturge-Weber. If not, please remember the triad for it is mostly port wine stain, tram track calcification, and glaucoma is the eye component which is seen in Sturge-Weber syndrome. So glaucoma is important, has been asked previously. Question 2, what is this disease? You can see a cauda equina is provided, a horse is given, a x-ray has been given, and this playing instrument is given, and this is a club foot, CTEV, which is congenital talipes equina varus. Question 3, here you can see in the chest radiograph, frontal chest radiograph, there is a classical appearance given, a boot-shaped appearance which is seen in cases of TOF. The involvement is on gene 22, and there is cleft palate also. So the diagnosis is Dijorge syndrome. It is also known by another name, which is catch 22. There is a TOF association with it, which can be seen on radiograph as a boot-shaped heart. And in the image, here you can see a cleft palate. Some image-based spotters. So this is a USG image, antenatal. So think of an answer in your mind. So here we can see that there are the bones of the fetus which are kind of overlapping, and this is known as Spalding sign, and it is a sign of intrauterine fetal demise, intrauterine fetal death. This image you can see the vertebra has been given. There is increased radio density sclerosis of the vertebral ends which are seen, and it is a case of rugged jersey spine. And rugged jersey spine is seen in which condition? You are thinking right. Rugged jersey spine is seen in cases of hyperparathyroidism. Next image, NCCT head image provided plain, where you can see low attenuation at the frontal region. So here we can see the attenuation like that of a ear, which can be seen in the bilateral frontal region. Decreased density, hypoattenuation, and this hypoattenuation which is seen at the upper region is given a sign which is known as Mount Fuji sign, and this Mount Fuji sign is seen in cases of tensor pneumocephalus. So this is a image based question for a tumor tensor pneumocephalus, and the sign is known by the name of Mount Fuji sign that you people are supposed to know. So we discussed a spectrum of radiological conditions, the image based connect the dots questions, the usual asked MCQs, and try to develop the approach if any radiological image or associated two-step question is asked, where first we have to identify the condition, seeing the radiograph or the stem of the question, and then again seeing the statement. After coming to a diagnosis, we have to know the statement and then we have to answer. So it can be a straightforward simple one step question in your FMG examination, or it can be associated question which are commonly asked these days. Best wishes to all of you. Keep studying. The entire game team is with you. If you have any query related to radiology, feel free to mail me. This is my mail ID, Dr. Ankit Singh 13 @gmail.com. Keep studying and best wishes. Thank you.